Okay, so we are talking about infectious or communicable diseases. There is a lot to cover here, and I would say this is the bulk of what gets tested in Gen Peds on your NCLEX because children are so susceptible to all of these childhood illnesses. So please take notes and try to organize your thoughts as we follow along. So just a quick review on the infectious disease process. So what's happening? There's a foreign organism which invades and then multiplies, causing cellular and tissue damage. Then you have blood, fluid, and other nutrients rushing to the area that cause inflammation, but ultimately the goal is to eliminate the foreign invasion and repair the damaged areas. And so you're getting both a vascular and a cellular response. And just a little cartoon there. When's the last time you all cleaned your cell phone? So we actually have to clean our cell phones in the NICU and PICU before we start our shift, and we ask parents to clean their cell phones every time they enter as well. Here's a cartoon of the white blood cell versus the common cold. So the white blood cell is saying nobody in or out, but this red blood cell notes that the cold virus has hot chocolate, so they let him in ultimately. So types of immunity, you all remember passive immunity. That's what's passed on from mother to baby via the placenta or breast milk. The one thing about passive immunity is that it's not long-lasting. Other examples are medications or artificial injections that we give at the hospital that provide antibodies. IVIG is one of those examples, and we use that in various situations, but certainly with exposure to hepatitis A, B, measles, tetanus, rabies, varicella, we can give IVIG. Another example would be an antitoxin serum that gives passive immunity. Botulism toxin is one of them, diphtheria is another. And then a third example of passive immunity given artificially is the antibody for respiratory syncytial virus. It's called Synagis, and we prophylactically give that to kids at risk during the winter months to prevent RSV. Adaptive immunity, which is more longer acting, you've got cellular immunity. So those are your phagocytes, T cells, and natural killer cells. Their job is to engulf and directly kill invaders. And then humoral immunity, that's your antibody-mediated response, most notably your B cells. They make antibodies and attach them to invaders for other cells to recognize and destroy. And here's a picture of all the cells involved. So there is some overlap between adaptive and innate immunity. B cells, T cells, natural killer cells. And then you've got cellular differentiation. You've got your neutrophils, eosinophils, and basophils. Your antibodies are then releasing IgA, IgD, IgE, IgM, and those proteins provide viral protection, allergy and parasitic infestation protection, and other antibody protections. So in the white blood cell line, the first line of defense, well, actually your first line of defense is going to be your skin and your mucous membrane. So that is the first line of defense, protecting you against foreign invasion. But once that invader infiltrates your bloodstream or your respiratory system, then you've got your white cells. So your granulocytes, they're involved mostly in phagocytosis. Your neutrophils, they are primarily involved in bacterial and fungal invasion, and then they clean up cellular debris. Your eosinophils, those are mostly involved in allergy and parasitic infections, and your basophils involved with allergy and chronic inflammation. And then you have your lymphocytes. They generate kind of a general immune response. They recognize antigens, and those are your B cells, T cells, and your NKs. And they go after viral infections and tumors. And then if you're releasing monocytes, that's your second line of defense, and that is for severe infections, leukemias, and severe inflammation. So when we are looking at a CBC in clinical practice, we're looking at not just what the white blood cell count is, but we're looking at the differential. So how many SAGs or neutrophils is the body churning out immature cells called bands that have not fully grown into a grown-up neutrophil. That can be an indication that there's an infection going on. With allergic processes, you're going to have high eosinophil counts or high basophil counts, not necessarily your neutrophils. And then in leukemias, we see high monocyte count. So every time we get a CBC, it gives us kind of targeted information, and then we match that with the symptoms that we're seeing. And here's just a diagram of the cells as they differentiate coming off of the bone marrow. So at the top, you've got your multipotential stem cell. So that is the most basic cell before he turns into whatever he is supposed to be when he grows up. And as you follow down the pathway, you can see how they differentiate on the right into natural killer cells, small lymphocytes, T and B lymphocytes, etc. And then on the left, the common myeloid progenitor turns into a megakaryocyte or a myoblast or a blast, and then it further differentiates. So if your body is making a whole bunch of immature cells like masts or myeloblasts, that tells you on your CBC that not only is this person fighting infection, but they've exhausted all of their mature cell lines, and now they're just churning out cells early, even though they're not ready to wage a full war. So we look at the whole piece, the whole thing that's going on with the CBC. Special considerations in pediatric populations. We've discussed some of these things before. You all know that kids have an immature immune system. In addition, a baby has a decreased inflammatory response. Their whole immune system is just very slow and sluggish at recognizing and when to send out special forces. So they don't mount a rapid response. And in fact, early newborns can't really even mount a fever against invading organisms. An infant that's less than 3 months, if they get really sick, they're more likely to have hypothermia, so inability to maintain a normal temp in response to invasions. Cellular immunity is functional at birth, and humoral immunity occurs when the body encounters and then develops immunity to new diseases, right? So the baby hasn't been exposed to all these diseases yet, so has not developed immunity to them. And in addition, the infant is slowly losing its passive immunity as time goes on. So, and then with older kids, potentially disease protection is not complete because they've not received their full vaccine series. And then, of course, you all know, especially in our current climate, that a lot of people are just not immunized. So in terms of your care, what is the chain of infection? You have your infectious agent, and this is a flyer from a Department of Public Health. So you have all of these infectious agents, bacteria, fungi, parasites, viruses. You have the reservoir, which could be a surface. It could be people, water. It could be air. Then you have the susceptible host. We have large populations getting exposed, but not everyone comes down with illness, right? You have the portal of exit from the affected person, and then the portal of entry on the person that gets exposed. And then you have all of these modes of transmission: contact, ingestion, inhalation, etc. So that's a fun poster on how to break the chain. And then we have the stages of infection once you've been exposed. The incubation period, that's your first exposure to symptoms measured in time. So depending on what illness, it could be hours till symptoms, it could be days, it could be weeks. And that gets really difficult then in preventing or tracking exposure to something like measles or chickenpox that have longer incubation periods. The prodromal phase is the time from non-specific symptoms to more specific symptoms. So, for example, with a lot of the childhood viral illnesses, they all kind of start with fever, runny nose, generalized not feeling well, maybe you have fatigue, but you don't have something specifically to call out, yes, this is chickenpox, or yes, this is measles. So before you develop those fluid-filled blisters that really declare that it's chickenpox, that's your prodromal phase. Time from those mild symptoms to more specific. The period of illness, that's when you have those symptoms that are specific for that infection or illness. And then the convalescence or recovery phase. So know the phases, know which stage you're in, know what to look for, and what your considerations are going to be, because those will be called out in critical thinking type questions. A note on fever before we move on. What is a fever? So the fever is the body's release of endogenous pyrogens. Those are inflammatory modulators in your body. So they trigger prostaglandin production, which causes pain, inflammation, and fever. It's like your alert system going off. And what is the purpose of a fever? When is a fever dangerous? So the purpose of a fever is to make the environment more and more hostile for the infectious agent. And I would say it's kind of open to discussion. If you have parents calling into a pediatric clinic, they don't want their child to be uncomfortable, so they're going to want to treat a fever. I try to, unless the fever gets dangerously high, I like to let the fever do its work in the body, and maybe use non-pharmacologic measures to bring the fever down at first if it does get too high. And there's more in your textbook on fever and when it becomes dangerous and when to treat. Children are notorious for having seizures related to fever that do not cause any long-term damage, but they can be quite frightening for parents. Okay, on to communicable diseases. So specifically, we'll be talking about bacterial and viral illnesses. In your book, there's a little more on zoonotic diseases. We don't see those quite as often here in the United States, but please read about those briefly. And then parasitic and helminthic illnesses, worms, things like that, those are also in the book. I'm not going to discuss that here. Okay, some things for you to consider as we go on. Questions you should be asking yourself and thinking about. So with each of these illnesses, who's at risk? Who's most at risk? What is your assessment? What tests should be ordered? And then what are your priority interventions going to be? And just as, and what teaching will you provide for the family? So some of the tests that we do when presented with someone with illness, a CBC, that's always a first. It gives us so much information. CRP is something that we use in the hospital, and it's not a marker of infection, but it's a marker of inflammation, and we just use it as informational. It just kind of adds to the whole picture. They also use that in heart attacks in adults because it's a marker of inflammation. Respiratory viral panel, those give us information about a whole variety of respiratory illnesses. If you have someone presenting with upper respiratory symptoms. And then a whole bunch of cultures, blood, surface. So surface can be off of skin, the nose, throat culture. You can do, if you have blisters or skin lesions, you can culture those. CSF, spinal culture would be really only if you have a patient who's having neurologic symptoms in addition to whatever else they're presenting with, and you want to screen for meningitis. And then urine and stool culture. So the bacterial infections, we have risk both in the community and then hospital acquired. So the most common that we hear about these days are MRSA and MSSA. So that's your Staph aureus, methicillin resistant and methicillin susceptible Staph aureus. And that's just talking about the type of antibiotic this bug is susceptible to. Staph aureus is a normal skin organism. It's on all of us. And it's one of those organisms that takes the opportunity to reproduce and invade if there's an opening. So a break in skin, basically. And staph infections can cause cellulitis. That's an inflammation or infection of the skin and the underlying tissue. It can travel to the bone and cause osteomyelitis. It can cause septic arthritis, where it infects the entire joint. And those patients then lose the joint there. And it can cause bloodstream sepsis. And then, of course, worst case, it could also travel into the spinal fluid and cause meningitis. Scarlet fever, which is caused by group A strep, also known as strep throat. We'll have pictures of that in a minute. And then diphtheria, pertussis, tetanus, and botulism. Those are all your bacterial infections. So here are some pictures of staph infection. And as you can see in the finger at the top and the arm, looks like we had some broken skin, and then the staph caused a localized infection there. And then the picture of the little baby foot with this really, really red, angry ankle, that's a cellulitis. If you can see on the x-ray of the joint, we have some osteomyelitis. That is a leg joint, a knee, and the bone should be white. So on the right-hand side of that joint, you see like an oval egg shape that is not quite as opaque, so not quite as white as the rest of the bone, and that's infection there. On the bottom right is a hip, and it's outlined on the patient. It's just, we do outline on the skin so we can see if infections are traveling and getting worse before they get better. So that's a patient that's lying down with a leg up. And then there's just a pictogram of an infected joint and what that would look like. Sepsis. Sepsis happens when the infection reaches the bloodstream, and you have, rather than a local infection, a systemic inflammatory response because of that infection. And they can go into septic shock and circulatory collapse pretty quickly. And certainly in at-risk populations, like otherwise immunocompromised children, they can have multi-system organ failure. So Sepsis does kill. Infections are still one of the leading causes of death in children at risk. And I don't think the general population realizes that. So scarlet fever, aka strep throat, there is a picture there of a common rash that one would see with strep, and the tonsils have this notorious big red angry appearance, but also with pockets of pus. So anytime we have someone coming in with sore throat, cough, and respiratory symptoms, we always look at the tonsils, and that's pretty notable for strep. And also the bright red rash on the face. Diphtheria, which is caused by Corynebacterium diphtheriae, very similar to, the other symptoms kids are coming in with: fever, sore throat, things like that. And they also, you can see in those tonsils there, white plaques with pockets of pus. So these are two throats that you would swab and send off to identify the organism. The difference with diphtheria is that it can cause damage to the heart. And the throat can swell up so much that they have airway obstruction. Incubation period for diphtheria is 2 up to 5 days. And usually, I think it runs its course in 2 to 4 weeks, but because it can be so dangerous in terms of the risk of heart failure, that's one of the things that we have immunizations for. Pertussis, also known as whooping cough commonly, this is caused by the bacterium Bordetella pertussis, so please know that name. The incubation period can be up to 21 days, but usually is about 2 weeks. And it is notable for this severe, prolonged period of coughing with a loud whooping sound. So there are a couple of videos here for you to follow the link to so you can see that. Pertussis can be very dangerous for young children. I've had infants that did not survive pertussis, and they were too young to have their full vaccine series and were exposed out in the community. So yeah, definitely something we want to make sure we have our boosters for. Adults will outgrow. I think the vaccine is effective up to 10 years, and then you need your booster. So we always counsel families that if grandparents are going to be babysitting, that they should make sure they've had their booster shots. Tetanus is extremely rare, at least in the US. Tetanus is caused by a spore that is found in the dirt, so difficult to prevent exposure because it's in our environment. It has a long incubation period, 3 up to 21 days, and it gets into the bloodstream through a puncture wound. So stepping on a rusty nail or getting a cut outdoors can lead to that. The picture there of the baby on the bottom, babies can also be exposed if that umbilical cord is cut with a dirty tool and there were tetanus spores on the knife or scissors or whatever was used. The hallmark is extreme muscle rigidity, which affects every muscle in your body. And so you can have, it can be in a sudden emergency where the person cannot breathe or swallow. And we do, as you know, have shots for that. So if you have a patient that comes in and got injured, I had someone a teenager recently who got stabbed with a knife in a fight, and so we gave him his tetanus shot. Botulism, exposure to botulism is extremely rare as well, but any of you that do preserving of your own food or canning, you know that there is risk of foodborne illness if things aren't prepared properly. You can also get botulism from a wound. Botulism, it's botulinum toxin, and it creates a neurotoxic protein that paralyzes the nerve cells in the body. It can be fatal. See, there's a baby ingestion of spores. There's a little bottle of honey. You can also get exposed to botulism through honey. Honey is not pasteurized, and so that's why we recommend that babies do not ingest raw honey until they're, I think, I don't know the cutoff. You'd have to look it up, but I think up until a year of age. Once your GI tract becomes more mature, the risk of exposure is less. So treatments to this are actually just supportive care. So if someone came in exposed and was paralyzed, you would give respiratory support or cardiorespiratory support until the effects of the toxin passed. We also have botulism immunoglobulin, which can help, and an antitoxin. Okay, viral illnesses. So again, who's at risk? What is your assessment of the symptoms? What tests should be ordered? Those are the things you should be thinking about. I tried to cram all of the viral illnesses into this table to try to simplify things for you. Viral exanthems, these are all the illnesses that produce a rash. Each rash has its own characteristics, so that's how you identify them from each other. And I also want you to think about, which I didn't really talk about going over bacterial illnesses, but you also want to be thinking about, in addition to the incubation period, the modes of transmission. And so we had that question last week with RSV specifically, whether that was droplet contact or airborne precautions. And so these are things that you actually need to know and need to think about. So I recommend you make a table and try to organize things for yourself. So rubella, also known as German measles, it's caused by the rubella virus. Incubation period is 14 all the way up to 21 days. And this virus is transmitted by direct contact with droplets, and it's also airborne. So can you imagine if someone who was carrying this disease was at Disneyland, and knowing that the incubation period could be up to 21 days, the number of people that you've exposed as a public health provider, it's a nightmare trying to contain something like this. So rubella usually presents with low-grade fever, malaise, a pinkish red maculopapular rash that starts on the face and then spreads down the chest and across the body. There can also be petechiae on the face and on the soft palate. So interventions, airborne, droplet and contact precautions if hospitalized. Certainly you want to isolate them. You don't want to expose them to other small children or pregnant people. Certainly wouldn't send them to school until things had passed. Rubeola, also known commonly as measles, and you all know about measles because it's been in the news a lot. Measles is caused by the measles virus, or also known as paramyxovirus. Incubation period is up to 20 days, and the communicable period is 4 days up to 5 days after the rash appears. So they're still spreading infection up until the rash appears, and then we think it goes down after that. Measles is also airborne and direct contact with droplets. It also can cross the placenta. So that's important to know if when you're doing pregnancy screening, if people have been exposed or come down with any of these illnesses. These patients also present with fever, malaise. What sets measles apart is what we call the 3 C's. Coryza, cough, and conjunctivitis. So coryza refers to the nasal redness and swelling. Cough, conjunctivitis, the redness, inflammation of the eyes. And then they also develop a red erythematous maculopapular rash that starts on the face and spreads downward to the feet. These lesions blanch when you press on them, and then eventually the lesions turn brown. They can also have spots on their mucous membranes, so when you look in their mouth, they could have bluish pale to white spots. So next is varicella, also known as the chickenpox, which is caused by one of the herpes viruses, herpes virus 3. Or in other references, they say varicella zoster virus. The incubation period is 13 up to 17 days, and direct contact or droplet, also contaminated objects. So if you're touching something that was exposed, so think of just children at school or daycare, they're touching everything. These kids present with fever, malaise, and then a rash that starts on the trunk and scalp and moves to the face and extremities. And then they develop into these fluid-filled blisters or pustules. It's notoriously very, very itchy. And then they crack or burst open, they dry and develop a crust. They can also get the skin lesions in really painful areas like the mouth and their private parts, which can be extremely uncomfortable. These kids need to be under strict contact and droplet precautions, and the kids should be isolated. For this virus, we actually, most kids today are being immunized, so it's in the immunization series. But if they do develop it, acyclovir, which is an antiviral agent, can be used to decrease the length of the disease. Okay, roseola, also called sixth disease, is caused by herpes virus number 6. We see this often in young children, toddlers, up to 2 to 3 years old, up to 5 years old. Short incubation, 5 up to 15 days. And this illness is notable for its sudden, very, very high fever, greater than 102, 103. And the fever persists for 3 to 5 days. The child otherwise is well, but then develops fever and then gets this rosy pink rash on the face and trunk, pink macules that blanch with pressure. And because of the high fever, these kids can have febrile seizures. It's pretty self-limiting illness. It only lasts a few days, and so mainly just supportive care. Next is erythema infectiosum, also known as 5th disease. This is caused by one of the parvoviruses, which there are many. This illness, the incubation period is typically a few days to 2 weeks. And The transmission is by droplet and contact. These kids get a rash, mild fever, headache, runny nose, so symptoms common to upper respiratory and just generalized malaise. But what's notable about this rash of the face is that it's what we call the slapped cheek appearance, where they get a very bright flushing of the cheek like they had been smacked in the face. And that's just how we tell that apart from the other viral illnesses. And then finally, of the illnesses that cause these viral rashes, we have hand, foot, and mouth disease. It's caused by one of the many Coxsackie viruses, and again presents with fever, sore throat, generalized not feeling well, and then they develop little vesicles, small, much smaller than a chickenpox blister. They're like pinpoint, but fluid-filled, and they develop on the palms of the hand, in the mouth, and on the feet, so can be very uncomfortable, and that's why it's called hand, foot, and mouth disease. So kids often present with what you think is just the common cold initially, and then develop these varied rashes across their body. So we will send viral panels and identify which illness it is, if they're very, very sick and you want to identify it. Otherwise, we just send them home primarily for supportive care until it runs its course. So what is the problem with all of these childhood viral illnesses? Usually they're mild and very self-limiting. They're a little uncomfortable. The kid stays home for a few days. It's no big deal. There's a range of symptoms: fever, sore throat, rash. Kids often can get nausea, vomiting, diarrhea, and just general aches and pain. So supportive care, you're going to provide fluids, nutrition, you can provide pain reliever, things like that, stuff for the sore throat, etc. But the problem with the childhood viral illnesses is that they can cause very serious complications. And although rare, not everyone will develop them, they can be pretty devastating. So pneumonia, pulmonary edema, meningitis, which can cause damage to certain areas of the brain, encephalitis, seizures, hearing loss, arthritis, arthralgia, and those things can cause lifelong disability for the people that are affected. And then, of course, we have all of our kids who can't get immunized because they are immunocompromised. Maybe they have cancer, or they have a immunodeficiency disorder, or they're babies and they've not been able to have their full vaccine series yet. So that is the problem with childhood viral illnesses and why we try to prevent them through vaccination. And there are a couple stories here that you can click through to. The link on the bottom is for the Department of Health for our state. And so as a provider, if we see any of these kids in clinic that have a vaccine preventable illness, we are required to report it to the state so that they can track things. And here's just an article I threw in on the lie that never dies, vaccines causing autism. And I think we're finally starting to break that myth. But here is just a link or a piece of the original article. So I'm not going to read that. We've talked about it in class. So immunizations. Sorry, let me go back. Immunizations, there's a great kind of review of the immunization schedules in your ATI book. I think that's a good resource for you to study them as you prepare for ATI. And then you'll also need to know those things on the NCLEX, the vaccine schedule. In general, you need to know what's given when. And then for viral illness, what are your key nursing interventions for each one? What teaching will you provide to families? For those affected and during acute illness, how will you manage fever, promote skin integrity, provide comfort, fluid balance, and nutrition? Those are the kinds of things you should be thinking about. All right, and that's it. Thank you. Here's a a drug-resistant bacteria. He was bored and so he evolved. But hopefully we can put a stop to that with, we're doing a lot with antibiotic stewardship. So in the old days, a lot of people would come with their sick kids and just want antibiotics for everything. We are very resistant to do that now. We have to confirm every bacterial illness before we treat in the outpatient world. And then in the inpatient world, if you have sick patients, we do often start antibiotics first while we're isolating organisms. And then once we decide that it's not a bacterial organism, we make sure to take the antibiotics off right away. All right, thanks everyone.